I'm an embryologist at Wilgers Infertility Clinic. It is my privilege to be able to address you today. And my talk is going to be very, very brief because I do believe that the subject that I'm speaking on is more for a fertility specialist to address, not for the embryologist. So I'm just going to give you, I believe everyone sitting here today has been in a doctor's office to discuss fertility. Am I right? Yes. Most of you have been there. So you do know what the information that I'm going to be giving you, you do already have been exposed to it. So I'm just going to give you some brief facts, and then I'm just going to talk from the heart as an embryologist, what I see in the lab. So first things first is the general stats. When we look at ovarian reserve, we look at your potential of having a baby, the eggs that we might potentially get to have a baby. Can you still hear me at the back? Yes. Okay, good. I'm not going to ask again, so just let me know if you can't hear me. Okay, so when you look at ovarian reserve, it is the amount of eggs that you have available to give us a viable pregnancy and the resulting baby. There are various tests, and if you go to Dr. Google, you will find a lot of information. This week, I went, not to Dr. Google, but I read a lot of academic literature. And I must admit, even as a scientist, I've been in the field for a very long time. I've written 2 theses, over 100 pages. I know a lot on eggs and sperm. And for me, with my experience, reading the information online is very daunting. So I think as a patient, that's why I don't have a PowerPoint for you today, because I don't want to scare you with the stats that you are already confronted with in the rooms. You already know what I'm going to tell you. So I'm just giving you the brief things that we do. Looking at ovarian reserve, we look at your fertility potential. And in doing so, there are a number of tests that we can perform. I'm sticking to basics. Basics would be your antral follicle count. That would be your AMH, your anti-Mullerian hormone reading, and your FSH reading. So let me know if you aren't familiar with these, but like I said, if you've seen a doctor, you would have heard these terms before. I'm just giving you the brief information about it. So antral follicle count is when you have that ultrasound in the rooms. Doctor visualizes your ovaries and she counts how many antral follicles you have. Important to note, antral follicle count is not your total ovarian reserve. It's just the ones that we can see on the ultrasound. So total ovarian reserve would be your primordial follicles, which you can't visualize on a scan. Your primordial follicles give rise to your primary follicles. Primary follicles give rise to your secondary follicles, and then your secondary follicles give rise to your antral follicles. Those are the ones we count. So it's actually your functional ovarian reserve, not your total ovarian reserve. Just important thing to note. If you have a count of 6 to 10 antral follicles, that gives us an indication that you have a good fertility potential. Hand in hand, with that, we measure AMH. AMH can be measured any day of the menstrual cycle, and it's your anti-Mullerian hormone, if you don't know what AMH stands for. And it correlates very, very strongly with your antral follicle count. So we use nanograms per milliliter, Dr. Daya. Nanograms, yeah. So nanograms per milliliter for a poor responder would be less than 1. If you are a normal responder or a good responder, we say good. If we want, let's say 8 to 15 eggs, we'd say your AMH should be between 1 and 3. And then you can correct me, doctor, please. Please, this is not in my wheelhouse. And then if you have more than 3, your reading is more than 3 nanograms per milliliter, that would indicate that you are a very high responder and at risk of over-responding or giving us a lot of eggs. So your doctor will give you less medication because we don't want 100 eggs. Right, so that is the second measure of measuring ovarian reserve. And then the third one is FSH, and that's also a very basic test. It's a blood test we measure on day 3. And I think, Doctor, I've simplified it, but under 10, FSH under 10 micro-international units per milliliter, that's fertile. So that's what we look at. If you're a female and your FSH is higher than that, we are worried, and we would be talking about donor eggs and all of that. So ovarian reserve testing, I think, and Doctor, maybe you can also just help me there. It's basically, it is an indicator of fertility, but it is more for the doctors, the clinicians, to know how to treat, what controlled ovarian stimulation protocols they will be using. So it's good to know, but it's more for knowing how to stimulate you and how to treat you in the lab, right? So that's the first part. Like I said, very, very brief. Second part, I'm talking about oocyte quality, and the more I went through the literature, the less I learned. Because the only thing in the literature that really talks about oocyte quality, I can call it egg quality if it's easier for you guys, that talks about egg quality is actually age. Age is the only indicator of egg quality, which for me, again, just underlined how negative the scientific literature is regarding fertility. So I wish there should be more indicators for us scientists to be able to gauge oocyte quality than just age. But nevertheless, age is the biggest determining factor for eggs. You should know when you are born with the amount of eggs that you will ever have, ladies. Guys have a factory. They produce sperm every 3 months. They've got a new batch of sperm, which is very unfair. But still, there is a term. Bob, you touched on it, andropause. So guys love to throw age at women, but guys, I would just like to inform you, andropause does exist. It's just 5 years delayed. So it's coming for you as well. I'm just saying. So looking at the stats, when you look at age and fertility, I took the stats from IVF Australia because IVF is, although we do have a national database and all of the SASRAC labs, all of us that are here today are part of the accredited SASRAC labs, but so we all have a national database for fertility, but the Australians and the Europeans might be sometimes, I think, on the forefront of IVF research and all of the figures. So I took their stats, and if I say that age is the main determining factor for oocyte quality, then I need to take into account pregnancy rates. This is now with IVF per age group. So age groups 30 to 34, which is your young age group, you've got a 43% chance of falling pregnant per cycle. Then your age group 35 to 39, you've got a 31% chance of falling pregnant per cycle for an IVF. And your age group 40 to 44, you've got an 11% chance of falling pregnant. Yeah, sorry, it takes quite a bit. I'm sorry about that. I'm going to try and rectify that in my own personal account when I'm speaking to you now. But also, I would be neglecting not to mention the risks associated with age-related pregnancies. So the first of those would be miscarriages. We see a lot more miscarriages in pregnancies after 35. We see a lot more gestational diabetes. Can you still hear me? And placenta previa. So those are the risks of age-related pregnancies. And I've given you the blood level reference ranges just so that you know what are the stats, what you need to know. And as a scientist, it is important that we have these units of measurement. It's important that we have the standards and the bars set so that we know what to expect. We know what is the reference in which we work within the lab. But as a scientist, just so that we have a realistic framework, so that we don't lie to you when you come to the lab. So we can tell you, this is what it should be, and your eggs did not reach this, your embryos did not reach this stage. So we need these reference ranges. But this is where the statistics on my end is going to stop. Thankfully, I don't have a PowerPoint. I can just go on. So this is where that ends, because I think when I started in the field in 2009, which is a long time ago, I was very much the academic scientist. I won the Chancellor's Medal for Science. I got an MSc from Stellenbosch. I was very academic. And as Dr. Deo started in the beginning by saying that, we look at a diagnosis, whose fault is it? As a young embryologist, we tend to label a couple as, the low sperm or the poor eggs or the, I'm sorry, it's the way we are taught. As I've grown up in the lab, these stats are the stats, and Dr. Deo and I spoke about this beforehand, because I said to her, I'm not gonna give you the stats because I don't believe in them anymore. And she reminded me, I need to give you the stats because it's the truth. It is the unit of measurement, it's the truth. But my experience in the lab is not this. It's not as low. So that's why when I was going through the statistics this week and preparing a speech and deciding on whether I would be speaking to you, as in having a conversation with you, and whether I would be giving you a PowerPoint presentation, I just decided I'm not giving you a PowerPoint because I'm not going to confront you with the statistics you already face every day. I think it's not fun. We have to know this. We do need to have a diagnosis. But it was also a nice reflection for me to see how I have grown up in the lab, from diagnosing a couple and seeing them as, low sperm, this. Now we treat this holistically, and you are a couple. So we need to know the diagnosis so that we can accurately treat you. But that's the only reason that we need the diagnosis. You are not the problem. So we see a lot of success in most of our patients are 39 and upwards. And although the statistics says 11%, I do want to give you hope and say that I feel that the statistics are much higher, because majority of those patients do come to our labs, and majority of them do go home pregnant. The only thing that we do need to counsel patients better on, and that would be all of you, would be that you need to be realistic in treatment. I see many patients come to me and they tell me they've done 7 IVFs. They've done 7 IVFs over the past 7 years. And to me, it's very sad that someone didn't counsel you along the road and tell you, what, your chances of falling pregnant gets higher per cycle, but it's not higher every year. So your chances cumulatively increase if you plan your cycles close to each other. So the statistics worldwide, most of you will go home with a baby if you do 3 IVFs and all of the frozen embryo transfers within a close succession of time. So I know that's something I'm throwing at you, and you're thinking I don't know what an IVF costs. I am aware. But statistically, if you want to go home with a baby, take a year or 2 or 3 and plan. Save the money so that you can really throw everything at it to go home with that baby. So yes, it's a hectic statistic. I'm sorry. And if you haven't been able to store embryos from a cycle, from a first or second cycle, you will need more, because the statistics include that it must be 3 IVFs plus all of the frozen embryo transfers we were able to do with that. So it's a lot. You need a lot of good quality embryos in order to have a baby. But there is hope. Like I said, the stats are the stats. But I do think and I do believe that IVF has grown a lot. Our success rates have gone up a lot. And as per cycle for a patient, the more cycles you have, the more data we have, and the more we know where we can tweak or change something in your treatment protocol in order to serve you better. So that's my talk. I don't really have anything else to add. Like I said, this is actually a fertility specialist topic, so I did my best to speak on ovarian reserve and oocyte quality, but it's really, the more we know, nothing has changed. The basics have stayed the same. So it's just very important. I do want to reiterate, and that's why I actually touched on the total ovarian reserve versus your functional ovarian reserve, is that I do believe lifestyle functions, lifestyle factors do play a very big role in your egg quality and in your fertility, in your IVF success. So I was laughing at you about the water drinking, but it's very important. It's very, very important. Keeping a healthy diet. It's more worth it taking a break from treatment, getting your lifestyle a lifestyle, cutting out excessive alcohol, cutting out excessive, smoking, bad lifestyle factors. You need to work on that, because in the lab we see a difference. I can have a 40-year-old in the lab who lives a healthy lifestyle with better eggs than a 30-year-old. So, and that's what we see, and that's why the success rates for older couples sometimes are much higher than the younger couples that should be falling pregnant easier. So that's just my take. Lifestyle can alter a bad prognosis, and it can actually assist and help you. So if anything, speak to the registered dietitians with your doctors and work on that, because it's very, very, very important. It impacts your sperm quality, it impacts your egg quality, and therefore your embryo quality. It's very, very important.